Okay, so the refractory periods. The refractory period is the period in the cell in which the cell depolarizes or the process of repolarizing. So it consists of two different phases. The first half represents the absolute refractory period. This is a period of time from phase 0 to the middle of phase 3, in which the ventricles have not sufficiently repolarized to enable another depolarization. They haven't fully cocked up yet. The second half represents the relative refractory period in the middle of phase 3 to the beginning of phase 4, which indicates that some cells have repolarized sufficiently to depolarize again, but not all of them, only some. And then you have the conduction system. So in the conduction system, there's specialized conduction tissue that is made up of specialized pacemaker cells. The pacemaker is the area of conduction tissue in which electrical activity arises. It sets the pace for your cardiac contraction and keeps it going in a rhythmic cycle. So the dominant pacemaker is your sinoatrial node. This is your SA node. It lies at the junction of the superior vena cava and the right atrium. So it's at the top, at the anatomical anterior view, it is at the top left-hand side of the heart. It lies at the junction of superior vena cava and the right atrium. It receives blood from the RCA. I don't know what that is. All right, in about 0.08 seconds, the electrical impulse generated in the SA spreads to the atria and advances through 3 internodal pathways. So from the SA node, we go to the AV node, the atrioventricular node. It is between the atria and the ventricle. So it's located on the floor at the right of the atrium behind the tricuspid valve near the opening of the coronary sinus. Basically, it's in the middle of the heart, not dead center middle, maybe a little bit up, but you're at about 1/3 of the way down to the heart. That's going to be where your AV node is. When an impulse from the SA node enters the AV node, it is delayed for about 0.12 seconds before it is relayed to the rest of the conduction system. This delay allows the atria to empty the blood into the ventricles. About 70% to 80% of the blood in the atria fills the ventricles by gravity alone. So it carries a lot of energy is saved this way. The remaining 20 to 30% comes from atrial contraction. The AV junction, including the AV node surrounding the tissue and the bundle of His, also called the AV bundle, conducts impulses from the AV junction to the left and right bundle branches. So here we go. This is the electrical conduction system of the heart. So like I said, you're at the top of the heart. This is going to be your SA node, your first line of defense. Its intrinsic beat is 60 to 100 beats per minute. The average person is, I mean, everybody's different, but like a healthy average person is about 70 beats per minute resting, 60 to 70 per minute. Me talking right now, I'm at 70. And then you have your AV node, your AV ventricular node. So this pacemaker is set between 40 to 60. So if this one fails, at least you have your AV node. It'll keep you going 40 to 60. Now, both of these fail. Now you're down to, I'm not sure where it's at, but you have your ventricles. That is your third line of defense as far as your pacemaker. It can keep it going at about 20. So it's at least, it's still perfusing, but you are probably at a decompensating state that you're going to need medication, electricity, and other interventions in order to keep you going. You have your atrioventricular bundle, goes down to the Purkinje fibers, and then you have your left and right bundle branches that each go to the ventricles of the heart. So that way, whenever the electricity fires, it tells it to squeeze all at once. Like so, not all at once. So you'll go left to here, right. So the heart doesn't squeeze the ventricles at the same time. Normally, impulses pass through the AV junction into the bundle of His and then moves rapidly into the right and left bundle branches on both sides. This is the interventricular septum. If the atrial rate becomes very rapid, then the AV junction can regulate the number of impulses that reach the ventricles. So even if your SA node is like firing, you know, like 200 or something, the AV is still gonna catch it and say, that's cool, but we're gonna go at 40 to 60. We're not gonna go that fast. If the atrial rate, they then spread to the Purkinje fibers. So an electrical impulse spreads across the ventriculars in about 0.08 seconds while the ventricles simultaneously contract. So yeah, here it's just showing the your intrinsic rates. So like I said, SA node 60 to 100, AV junction 40 to 60, Purkinje network 20 to 40. The more that you read this and hear it, the more that you won't forget it. So you have abbreviations, yeah, we know that, atrioventricular. Accessory conduction pathways. So extra heart muscle tissue that connects the atria and ventricles, bypassing the AV node, you have the James fiber. This is in the atrial internodal pathways, and it extends into the ventricles by passing the AV node. Then you have your Maheim fibers. It is in the AV node, the bundle of His, and the bundle branches. This extends into the ventricles and provides a common pathway for re-entrant dysrhythmias. So if your heart gets on a cycle where it just keeps firing over and over again, and it shouldn't be, it's probably going through the Maheim fibers. Then you have your bundle of Kent. So it's typically located between left atria and the left ventricle, although it is sometimes found between the right atria and the right ventricle. It enables a depolarization wave to bypass the AV node and trigger early depolarization in a section of the ventricular tissue. Simultaneously, depolarization travels through the AV node and the bundle of His into your bundle branches. These simultaneously depolarized events create a change on the ECG tracing called a delta wave. So you'll see your T wave, and then you will see a very slight delta wave, if you can even see it at all. And then this can also trigger tachydysrhythmia, so your heart's gonna speed up. The autonomic nervous system in the heart, the effect on the heart and the sympathetic and parasympathetic divisions of the autonomic nervous system. The sympathetic nerves are in specific areas of the heart's electrical system and atrial muscle and the ventricular myocardium. So these nerves transmit commands releasing norepinephrine. Norepinephrine travels to the SA node, the AV node, and the ventricles to tell it what to do. To prevent buildup of lactic acid, the heart's going to speed up. It's going to increase cardiac output. An accelerated heart rate shortens all phases of the cardiac cycle. Whenever the ventricles have less time to relax, less time is available for these chambers to fill up adequately with blood. So the faster the heart's going, it's not able to catch all of the blood that it's trying to. It's just constantly catching and release, and there's a period that it's not able to fully relax and fully contract. I'm trying to think of, like, my example I would come up with was whenever I was in rowing, and you know, if we're rowing the boat and we're going too fast and your legs, you know, you can't keep up, you're trying to take shortcuts just to keep up with whatever the pace is set at. So let's say that we're rowing at like 50 beats per minute instead of like a relaxing 20, then I'm not gonna fully contract my body all the way to the apex of the row and then pull it all the way back. I'm gonna stop at some point that's short, which means that's a small lack of power that I could have used during that whole press to row the boat. So same thing's happening with the heart. When it's beating too fast, it can't get the full row out of itself as the heart. Just like I can't get the full row out of my boat, and now that much energy is wasted. Now I just got second place. An accelerated heart shortens all phases of the cardiac cycle. Yep. When the ventricles have less time to relax, less time is available of the chambers to fill up with blood. CO decreases, and signs of myocardial ischemia may appear. So you're going to have some pain happen. So this figure shows the sympathetic and parasympathetic nerve fibers and their organs. All right. So connecting the SA nodes and the vessels of the parasympathetic, this is going to be in your medulla, and then you have your thoracolumbar nerves that are all within your thoracic portion of your spinal cord. And you have your adrenergics, I believe, no, adrenal glands are on the kidneys. Okay, so you have your cholinergic, your adrenergic, and then your dopaminergic. So this connects the renal glands to the vessel. Okay, so this is on the kidneys too. And then this connects sweat glands. So cholinergic is sweat glands, dopaminergic connects renal glands to the vessel, and then your adrenergic connects ventricles to the vessels. And these are all within the sympathetic nervous system. Parasympathetic nerve fibers supply the SA node and the atrial muscles to the AV junction of the heart by way of the vagus nerve. Vagus nerve does a lot. Vagus nerve innervates functional areas and it decreases the heart rate. You can stimulate the vagus nerve in multiple ways. So stimulating includes increasing pressure on the carotid sinus right about here, and also straining forced exhalation against a closed glottis, or we call it the Valsalva maneuver. So we'll hand somebody a syringe, we'll tell them to blow into it. Obviously they're not going to be able to blow as much air because there's a restriction there, but this forced like air that's putting pressure on the back of their throat is going to stimulate the vagus nerve. If somebody's heart is beating too much, this is going to tell it to slow down. And it's very natural and it's very least invasive. We're going to try that first, unless of course they're completely unstable. We're going to jump straight to electricity at that point. So in the early stages, we can use the Valsalva maneuver. Distension of a hollow organ such as a bladder or stomach. So yeah, this happens whenever in pregnancies. A lot of women, depending how they sit or how they lay, if the baby moves a certain way, the baby could stimulate the vagus nerve and then cause a drop in blood pressure and heart rate. So if the brain senses that the heart should slow its pace, an electrical impulse travels down the vagus nerve to the SA node. The electrical impulse stimulates the release of acetylcholine, ACH. Acetylcholine signals the SA node to decelerate the heart rate. Another acetylcholine molecule travels to the AV node, ensuring that no additional impulses can get through. So this figure shows the electrical impulse and how it stimulates release of chemicals. So your medulla is what tells the heart what to do. So you get an electrical impulse, goes through the vagus nerve, goes to the SA nerve here. And acetylcholine is released to suppress actions of the SA node and then tell the heart rate to decrease. Baroreceptors and chemoreceptors. So you have different receptors at different locations all along where your arteries are and your veins are in different parts of the heart, and it's where your nervous system is connected as well. So your baroreceptors are sensors composed of special nerve tissue. These are also known as pressor receptors. They're found in internal carotid arteries and the aortic arch as well. So at the top of the heart, your aortic arch, there's a baroreceptor there. I believe you also have one here at your carotid. So these will detect changes in blood pressure, and when your body detects a change in blood pressure, it detects it through the baroreceptors, and it's telling it, okay, well, let's do this. We're going to compensate by speeding up the heart now because blood pressure is too low, or maybe we're going to constrict the blood vessels in order to up blood pressure. So it generates a reflex in response to either the sympathetic or parasympathetic division of the nervous system, the autonomic nervous system. Chemoreceptors are located in the internal carotid arteries, the aortic arch, and the medulla to detect changes in concentration in the blood. So different concentrations there's different levels of oxygen. If there's not oxygen, there's carbon dioxide, right? That's what we're exchanging in our blood vessels. There's also hydrogen ions. So these are a pH that determines how base or acidic our blood is. Causes either sympathetic or parasympathetic response to changes. So we have different causes of cardiac dysrhythmia. We're gonna look at some of these. All right. So your autonomic nervous system imbalance, you have acid-base disturbance, central nervous system damage, certain poisons. Organophosphate's a big one. We would treat with atropine if somebody had an organophosphate overdose. Acid-base disturbance, I'm trying to think of a case where that would happen. Somebody's going into, if they're, on the bad side of a heart attack, the shaft end, their acid base is going to be heavily disturbed. So we'll be hitting them with things like sodium bicarb in order to combat that. Certain central nervous system, if somebody gets in a car wreck and they mess up any of their spinal cord, that could do that. Cor pulmonale, right ventricular failure caused by pulmonary disease. Distension of cardiac chambers, such as in heart failure, maybe they have myocardial infarction happening, death of tissue. Drug effects, phenothiazines, tricyclic antidepressants, and drugs used to treat dysrhythmias, such as adenosine, atropine, any of the type. You have electrolyte disturbances, especially involving potassium, calcium, magnesium. If you eat too many bananas, maybe you have a potassium overdose. Too much milk. Endocrine disorders, you could have hyperthyroidism or hypothyroidism, depending on if you're putting out too many hormones or not enough hormones. Hypothermia, to get too cold. Hypoxemia from any cause. Increased sympathetic output, increased vagal parasympathetic tone, myocardial ischemia or infarction. Normal variation, I'm not sure what that one is. Rheumatic heart disease, I'd have to look that up too. Trauma, if someone cuts their leg off, they're gonna have issues. Electrocardiogram, so this is our graphic record of the change in voltage that occurs in the heart muscle during depolarization and repolarization. This is how we can read the heart through lead 1, 2, and 3. Provides detailed information about the heart's conduction system. All right, electrode placement. This is the first thing that you will be roasted on and learn whenever you become a firefighter, whether you're a paramedic or not. They'll teach you. All right, so you have green, red, black, white. One easy way to remember this, you have smoke over fire, black over red, white, clouds over grass, right? Imagine you're in a field, grass, clouds, smoke, fire. Predetermined spots. All right, basic principle, best skin contact to minimize artifact and signals. Minimize artifacts. So get the best skin contact that you can. Make sure it's all the way on there. One way to do this, if they have body hair, shave it. Rub electrode site briskly with a dry gauze pad. Make sure there is not water between it. We're going to attach the electrode to the ECG cables before placement and confirm the correct location on the patient. Turn on the monitor, print a sample rhythm strip, and check for artifact. When you're in a bouncing, moving ambulance, you are getting nothing but artifact. Deal with it. To properly perform cardiac monitoring, drills 7-1, blah, 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 blah. Okay, so you got limb leads, you got precordial leads. These are what each leads are separated into. So the augmented limb leads, AVR, AVL, and AVF. So your AVL is going to be right, AVL is going to be left, and then AVR is going to be right. AVF is down below. It is a straight arrow going down. And then you have your, I'm skipping ahead. Okay, frontal plane leads, lead 1, 2, and 3. Let's see if I can remember which direction these go. Lead 1, lead 2, lead 3. Lead 1, lead 2, lead 3. Starting on the right side, starting on anatomical, on the right side, lead 1, lead 2, lead 3. All right, here we go. Lead 1, lead 2, lead 3, just like that. Okay, perfect. So you have your negative, positive, positive, and that's why that matters. And this is called the Einthoven triangle. Einthoven's theory, because William Einthoven discovered this, that the heart emits electrical energy every time that it contracts. So the whole point of the lead system, like each one of these leads is detecting electrical activity in the body. okay? And your central nervous system, this is where all of your electric activity is going down your spine. That is your central nervous system. And you have little parts of electricity all around you, no matter what, but like this is where it's all coming from. Also where the heart is. The heart is the power battery. It's not a battery, but it is holding in, conducting the most electricity compared to any other part of your body, which is why when we put these leads on the body, we can detect electricity from the heart from different directions, depending where you put the leads. So whenever you're looking at your QRS and you have on your electrocardiogram, it's shooting straight up, that means that there is electricity going straight to the lead. Now, whenever it is going down, that means there's electricity running away from the heart.